Now we want to speak about the step-by-step procedure of the socket shield technique. And we want to go in detail how you should perform the surgery today. This is the patient where we want to address the step-by-step procedure with the socket shield technique. This patient said he doesn't have time he doesn't want to have orthodontic extrusion. He doesn't want to wear some templates to bring the tooth down. He said he wants, if it looks like this at the end, like it looks now, then he's happy. Still, we have to think about a provisional solution. This is very important for him, since he doesn't want to wear a template. And I don't like, or we don't like to use resin bonded bridges. When they lose them, they need to come in the evening and to to re-cement them, or that's something we don't like so much. So the best provision, in our opinion, is the palatal implant. And when this patient, for instance, he doesn't care what it costs, he does want the best treatment, then we did a palatal implant. So we place a palatal implant 3 weeks before the surgery. Very simple and easy. This is a 3-minute procedure. And then you take an impression, a digital impression, and you send those data to the lab, and the lab can create you the perfect provisional for this situation. So now we are ready to do the procedure. Provisional is there. It's a screw retained provisional on a palatal implant. Patient is oriented, and you do the planning. You have done the CBCT analysis, and you have a navigation template ready to place the implant in the perfect position. So the first thing what we do is we remove the clinical crown on the level of the gingiva. So you take a diamond burr and you just grind down the clinical crown and maintain the tooth whenever possible to the level of the gingiva. And now you remove in this tooth all old root canal material when the tooth is root canal treated, or you remove all composite inside the root. This is very, very crucial. A burr goes easily through the dentin, but not so easily when there are leftover of composite or root canal filling material. After removing all the composite and all the old root canal filling material, tilt to the apex. Once you have done that, everything is removed. This is a picture who shows you that you also can use this burr. And now you start with the preparation of the implant bed through the root. Now you take your template. Then you go with your 2mm drill a little bit inside your tooth structure, like here. You can see this beautiful here. And you see typical location, how you are going to place an implant in the aesthetic zone, namely more to the palatal side. Then when you went down with the 2mm drill, you take the next drill, the 2.8mm drill. You just follow the first preparation with the 2mm drill. This is not so difficult. Here, you can do fully guided, whatever you want, or you can rely on your skill, on your dexterity, on your experience. Everybody should do it the way he's more familiar with. At the line angle, with our small burr, with our small Lindemann burr, we cut a little bit towards the periodontium on both sides, and then we remove now the palatal part of the leftover of the root. Now we can remove it, and please try to remove it first with a microblade. Be as gentle as possible. The preparation is done first, as you can see in the next slide. The preparation is done here first with the carbide burr. With the carbide burr, you can remove the root material a bit easier. The carbide burr has a diameter of 3 millimeters. Most of the time, not all the time, but when the buccal bone is there, most of the time you have about, on the buccal side, a dentogingival complex, which is about 3 millimeters. Now you can imagine why we have a 3 millimeter carbide burr. The 3 millimeter carbide burr tells us we go with our burr, we can look from buccally, and we want to see that the whole carbide burr is completely behind our gingiva. Then we know the preparation is till to the level of the bone. In the next slide, you see how we use then, after we thinned out the shield with the carbide burr, we use then the diamond burr, and we provoke coronally a little bit the bleeding. You can see this here beautiful, how it starts to bleed coronally. It's only a little bit. It is delicate. It is delicate. It is understanding the biology where you work with your instrument now. It is, you are more or less a prosto guy now. You work on healthy tooth structure. There is nothing which is not healthy of these tooth structure. There is everything healthy tooth structure, and you work now as a prosto guy, like a prosto guy, on healthy tooth structure when you make the final design of the shield. And it gets more or more in the form which you have designed in your CBCT analysis. Now, when you are finished with the preparation of the shield, following all these ideas and all guidelines I gave you here now, then before you place your implant, you have to check the integrity of the shield. This is mandatory, absolutely mandatory. Don't forget that. So that means you place on the inside of the shield a drop of toluidine blue. So the same staining fluid what the endo guys take when they do an apiectomy. And then we are ready. Now we know our shield will be anchored, in this case now buccally. It's a class 1, straightforward. We have a little buccal bone. So this is the easiest case. Then we place our implant, and the implant will have no contact with the shield in the coronal part. Only apically, buccally, there will be the contact. This is how it looks like after you have placed the implant. And we have gaps created, so the blood can seed in there between the implant and the bone, and therefore also the bone will be able to grow in there and create bone between the shield and your implant surface. Now, when we use a tissue level implant, we need to use a bone profiler to make sure that the titanium provisional abutment will fit perfectly on the implant. And then the next step is to manage the gap between the implant and the shield. Do we add some grafting material there? Yes or no? In this situation here now, I don't add any grafting material. It's too small. And so we just let Mother Nature create there in this gap some bone. But what we have to do is we have to create an individualized or customized healing abutment. This is important. Or, if possible, always try to do an immediate provisional. Sometimes this is not possible. Then you place on the implant a provisional titanium abutment, then a piece of rubber dam, and then you add a composite material which is designed for post and core buildup. Why? Because the composite material which is designed for post and core buildup does cure much faster in the deepness. And so when you add here this composite and you go with your lamp and you cure it much faster. And then here you take it off, and outside of the mouth you create now the perfect emergence profile. Tilt to the gingival margin from the base of the titanium abutment to the gingival margin. You create a concave shape of your customized healing abutment. Sometimes, like in this case, apically, we had a fenestration. Then you can do guided bone regeneration at the same time. And then you finalize the customized healing abutment, you screw it on, and you remember we have, in this case, created a screw-retained provisional on a palatal implant. This is the easiest and best way for provisional, no doubt, after an immediate provisionization. Make sure that between your pontic, which is on this implant, on the palatal implant, and your individualized or your customized healing one is some space, because this has a little bit resilient and you don't want that this superstructure doing biting will always touch your customized healing abutment. This is the situation after finishing the surgery. You see here the radiograph, a little bit strange because of this provisional. And now you wait. How long you wait depends a little bit about how much or how many millimeters of remaining bone you have and your implant is stabilized. So between 2 to 4 months, you can place the final crown on it. This is now another beauty, about this technique. What is the real beauty about this technique is that the morbidity after the surgery is zero. The patient has no pain, no swelling. You have no second surgical site. You don't have to harvest some more connective tissue and the pain the patient has there where you harvest your connective tissue. You always know that. And with this procedure, it's amazing. No pain, no swelling. This is the beauty about this technique, and you can finalize the cane within 2-3 months when your implant is in 4-5 millimeters of remaining bone. No problem. Sometimes you also have to wait a little bit longer, but depending on the situation. But the patient is really, really satisfied with you because this is what he wants from you. One surgery, everything done, no pain, no swelling, no hematoma. That's the wish of our patient.